At the beginning of the physical examination, the student provider should initiate the general survey upon walking in the room by discreetly assessing the patient's apparent state of health, level of consciousness, signs of distress, facial expression, posture, gait, motor activity, grooming, and hygiene. For vitals, we'll start with heart rate. Using the pads of the index and middle finger, compress the radial artery until a maximal pulsation is detected. If the rhythm and rate seem regular, count the beats for 30 seconds and multiply by 2. Count for a full minute if the rate and rhythm seem abnormal. For respiratory rate, count the number of respirations in 1 minute by visual inspection of the patient's chest. Observe the rate, rhythm, depth, and effort of breathing. Attempt to observe the respiratory rate while pretending to examine the heart rate as not to alert the patient and cause breathing changes. For blood pressure, palpate the brachial artery for a viable pulse. Position the arm so the brachial artery is at the level of the antecubital crease at heart level. Center the inflatable bladder over the brachial artery. Secure the cuff snugly. Position the patient's arm in a flexed position to determine how high to raise the cuff pressure. First, estimate the systolic pressure by palpation using the gold standard method. Palpate the radial artery with the fingers of one hand while rapidly inflating the cuff until the radial pulse disappears. Read the pulse on the manometer and add 30 millimeters of mercury. Use this as the target of subsequent inflations. Deflate the cuff instantly and completely and wait 15 to 30 seconds. Place the diaphragm of the stethoscope over the brachial artery and inflate the cuff rapidly again to predetermined level and then deflate it slowly at a rate of 2 to 3 millimeters of mercury per second. The first sound heard is the systolic pressure. Continue lowering the pressure slowly until the sound becomes muffled and then disappears, making sure to listen another 10 to 20 millimeters of mercury before rapidly deflating the cuff to 0. The last sound heard is the diastolic pressure. Perform this on the other arm. Next, for temperature, using an oral electric thermometer, insert the thermometer under the patient's tongue and ask the patient to close both lips until the digital reading appears. Make sure to completely expose the patient. Using the diaphragm of the stethoscope, auscultate the heart with the patient lying supine with the head elevated at 30 degrees. Listen to the heart sounds at the second right intercostal space, the second left intercostal space, the fifth intercostal space at the left sternal border, and the left fifth intercostal space at the midclavicular line. Note any murmurs or extra heart sounds. Using the diaphragm of the stethoscope, auscultate the lungs anteriorly and posteriorly as the patient breathes with the mouth open and slightly more deeply than normal. Listen to the breath sounds, noting any abnormalities or to simply assess the patient's baseline. Ask the patient to breathe facing away from you and listen in 3 positions bilaterally and symmetric anteriorly. Listen in 5 positions bilaterally and symmetric posteriorly. Take note to place the stethoscope on the skin, not over clothing. Also, be sure to show the patient the genie position for when you are listening to the posterior sections. Next, we'll start with the HEENT exam. We would start with inspecting the head for lesions and signs of trauma. We would then palpate the temporal and masseter muscles. We would ask the patient to clench the teeth, noting strength of muscle contraction, and then ask the patient to move their jaw side to side. We would then move on to the face. To test the 7th cranial nerve, we would ask the patient to smile, frown, raise both eyebrows, close their eyes tight, and puff out their cheeks. Next, we would inspect the eyes, eyelids, sclera, cornea, and lens bilaterally. Using tangential lighting, check for shadows in the anterior chamber, inspect the pupils for size, shape, and symmetry, check for the corneal light reflex by standing 2 feet directly in front of the patient while shining a light onto the patient's eyes, and ask the patient to look at it. We would inspect the reflections in the corneas. Next, to test for visual acuity, we would first ask the patient if they wear any types of corrective lenses. We would then give them an index card or something to cover one of their eyes, and then we would take the Rosenbaum chart and put it approximately 14 inches away from their line of vision. We would then ask them to read the smallest line they were able to see, and then switch eyes and do the same thing on the other side. We would then have the patient uncover both eyes and read the smallest print possible again. Next, to check direct and consensual pupillary response, we would ask the patient to look in the distance. Place a hand or a card on the nasal bridge, shine a light obliquely into each pupil, first looking for constriction in the same eye, then for constriction in the opposite eye. We would then repeat in the opposite eye. To test for extraocular movements, we would ask the patient to follow your index finger as you flow through the 6 cardinal directions of gaze. We would do this by tracing a wide H in the air and pause after each stroke to detect any nystagmus. We would then move toward the bridge of the nose to test for convergence. Next, we would measure lid lag by asking the patient to follow your finger as you raise it up slowly and then quickly lower it down to midline. To test visual fields by confrontation, perform the static finger wiggle test. Ask the patient to look at your eyes. Place your hands about 2 feet apart, lateral to the patient's ears. Simultaneously wiggle both fingers and bring them slowly forward, making sure to curve inward toward the central vision line. At each position, have the patient tell you as soon as they see the finger movement. Check superior, lateral, medial, and inferior fields bilaterally. Test accommodation by holding your finger or pen about 10 centimeters from the patient's eyes at the level of the nose. Ask the patient to look alternatively at it and into the distance directly behind it. For the fundoscopic exam, you want to first darken the room to assess the retina. To avoid bumping into the patient's nose, hold the ophthalmoscope with the right hand and use the right eye to examine the patient's right eye. Hold it with the left hand and also go left, left, left. Tell the patient to look straight ahead and position yourself 15 inches away at an angle 15 degrees lateral to the patient's line of vision. Shine the light beam on the pupil and look for the orange glow on the pupil. This is called the red reflex. Move in on the red reflex until you are very close to the pupil. First, visualize a blood vessel and follow it centrally to locate the optic disc. Next, inspect the retina, including the arteries, veins, fovea, and macula. Do this by inspecting from the disc to the macula in 4 directions. Finally, you want to ask the patient to look directly into the light to inspect the fovea and the macula. Next, inspect the auricle of the ear and the surrounding tissue. Palpate the ear in the mastoid process, checking for tenderness and pain. Use an otoscope to inspect the ear canal. Straighten the ear canal by grasping the auricle firmly, pulling it upward and backward and gently away from the head. Hold the otoscope between your thumb and fingers. Support your hand against the patient's face. Direct the speculum gently into the ear, positioning it slightly down and forward through the canal to visualize and inspect the canal and the tympanic membrane. Finally, you want to smoothly exit the speculum out of the ear canal. To test the acoustic nerve, perform gross auditory acuity by performing the finger rub test. Standing behind the seated patient, have the patient close their eyes and occlude their non-test ear with a finger over the tragus. Rub the pads of the thumb and index finger about 2 inches lateral at the level of the ear meatus. Ask the patient to state when they are unable to hear the rubbing as the student slowly draws their fingers laterally away from the meatus. Measure the distance, perform this test on the opposite side, and compare both sides. Next, perform the Weber test for lateralization. Strike the fork briskly, placing the base of the tuning fork firmly on top of the patient's head at midline. Ask if the patient hears the sound on one side or both sides. To compare air conduction to bone conduction, perform the Rene test by placing the base of a lightly vibrating tuning fork on the mastoid bone behind the ear at the level of the canal. Ask the patient if they can hear the vibratory sound and to vocalize when the sound diminishes. Once they no longer hear the sound, withdraw the tuning fork from the mastoid bone and quickly place the U portion of the tuning fork close to the ear canal. Establish if the sound can be heard again. Inspect the nasal cavities bilaterally with an otoscope by tilting the patient's head back slightly and gently inserting the speculum of the spoke into the vestibule of each nostril. Plant the handle of the otoscope to one side to avoid tapping the patient. Inspect the nasal mucosa, turbinates, and septum, directing the otoscope in slight movements. After removing the otoscope, palpate the maxillary and frontal sinuses. Make sure to press up on the frontal sinuses from under the bony brow. Under the cheekbones, press up on the maxillary sinus. Next, to assess the throat and mouth, we'll ask the patient to open their mouth to inspect the buccal mucosa, hard palate, pharynx, teeth, and gums. Make sure to use a gloved hand and a bright light. To assess the glossopharyngeal and vagus nerve, ask the patient to say ah while you visualize the rise of the uvula and soft palate with phonation. Next, listen to the patient's voice, followed by asking the patient to swallow. Check for the gag reflex, asking the patient to say ah and lightly stimulate either side of the uvula on the soft palate. Evaluate the hypoglossal nerve by inspecting the tongue at rest. Ask the patient to stick their tongue out and move it side to side. Then check the strength by having the patient push the tongue up against the inside of the cheek as the student palpates the cheek externally. Next, we'll inspect the neck externally, and then we'll palpate the lymph nodes using the pads of your index and middle fingers. Move the skin over the underlying tissues, testing both sides simultaneously. Palpate the preauricular, postauricular, occipital, posterior cervical chain, tonsillar, submandibular, submental, anterior cervical chain, deep cervical chain, and supraclavicular nodes. To palpate the deep cervical chain, have the patient rotate their head towards the side being examined. For supraclavicular nodes, have the patient shrug their shoulders and palpate the depressed angle above the clavicle. To test the spinal accessory nerve, ask the patient to shrug both shoulders upward against downward resistance of your hands. Next, ask the patient to turn their head from side to side against the resistance of your hand on their cheek and jaw. Assess the musculature of the cervical spine and surrounding structures first by inspecting, then by palpating. Palpate the spinous processes from the base of the skull down to vertebra C7, also palpating the muscles just lateral to the spinous process. Next, test for cervical spine active range of motion, making sure to stabilize the shoulders. Ask the patient to bring their chin to their chest, look up at the ceiling, look over one shoulder and then the other, and to bring their ear to their shoulder. Next, we're going to check the musculoskeletal exam of the upper extremities by inspecting and palpating for touch. Then we'll assess the upper extremities against resistance. Abduction and adduction, flexion and extension, flexion and extension at the elbow joint, flexion and extension of the wrist, ulnar and radial deviation of the wrist. Then we're going to check grip strength, opposition by the thumb, and then lastly we will check abduction and adduction of each fingers. To examine the sensory system, the student will start with light touch sensation using a fine wisp of cotton to touch the skin lightly. Make sure the patient's eyes are closed, have the patient respond whenever touch is felt, and to compare one area with another. To assess the 3 branches of the trigeminal nerve, brush the forehead, cheek, and jaw symmetrically on each side. Continue this pattern with the inner forearms, outer forearms, thumbs, and the 5th finger. Make sure to compare bilaterally. Compare proximal to distal upper extremity by brushing the shoulder, then the thumb, and ask the patient if they feel the same. To assess pain sensation, use an appropriate sharp object, occasionally substituting the blunt end as a control stimulus. Beforehand, ask the patient to report whether they feel the touch as sharp or dull. The patient's eyes must be closed. Compare sides bilaterally, testing the 3 branches of the trigeminal nerve at the forehead, cheek, and jaw. Continue this pattern with the inner forearms, outer forearms, thumbs, and the 5th finger. Make sure to compare bilaterally. Compare proximal to distal upper extremity by poking the shoulder, then the thumb, and asking the patient if they feel the same. Test cerebellar functioning using the finger-to-nose test. Instruct the patient to touch your index finger, then touch their nose, and repeat by alternating several times. Make sure to move your finger in different locations so the patient has to alter directions and extend the arm fully. Next, ask the patient to walk across the room, then turn and tandem walk on their way back. Examine for coordination and stability. Next, test the deep tendon reflexes on the upper extremities. Holding the reflex hammer loosely between your thumb and index finger, strike the tendon using a rapid wrist movement. To test the biceps reflex, partially flex the elbow with the palm down. Place your thumb on the biceps tendon and strike the reflex hammer aimed at the biceps tendon directly on the digit. Test the triceps reflex with the patient seated. Flex the arm at the elbow and internally rotate the shoulder, allowing the forearm to dangle. Gently support the antecubital crease with your free hand while striking the triceps tendon. Test the brachioradialis reflex by instructing the patient to rest their hand on their lap with the forearm slightly pronated. Using the flat edge of the reflex hammer, strike the radius about 2 inches above the wrist. Lastly, check for wrist clonus by supporting the forearm just above the wrist with the palm of the hand facing down. Flex and extend the wrist a few times before sharply extending the wrist, maintaining it in extension. Next, we'll do discriminative tests. To assess the sensory cortex, screen the patient using stereognosis. Place a familiar object, such as a coin and a pen, in the palm of the patient's hand. Instruct the patient to manipulate the object with only that hand and have the patient identify the object.